Dear participants, in this lecture, I am going to discuss about the anatomy of maxilla and associated structures with its applied aspect related to local anesthesia. Well, maxilla is the largest bone of the face excluding the mandible. It is more porous, cancellous in variety, leading to a significantly greater incidence of clinically adequate anesthesia. Maxilla has got one body and four processes. Body has got four surfaces: anterior or facial surface, posterior or infratemporal surface, superior or orbital surface, medial or nasal surface. Maxillary sinus is lying within the body of maxilla. The four processes of maxilla are the frontal process, the zygomatic process, ulnar process, and the palatine processes. If we talk about articulations of maxilla, maxilla articulates superiorly with the frontal bone, lacrimal bone, and nasal bone. It articulates medially with ethmoids, opposite maxilla, inferior nasal concha, palatine, and vomer bones, whereas maxilla articulates laterally with zygomatic bone. The anterior or facial surface of maxilla is directed both forwardly and laterally. The most prominent eminence on the anterior or the facial surface of maxilla is found over the canine tooth, and it is often referred to as canine eminence. Now, superior to this canine fossa, just distal to the canine eminence, is the location of the infraorbital foramen, which lies almost 5 mm below the inferior orbital margin. From this foramen, infraorbital vessels and terminal branches of infraorbital nerve emerge. The superior or the orbital surface is smooth, triangular, and slightly concave. Its anterior border is formed by part of infraorbital margin. Its posterior border is formed by anterior margin of inferior orbital fissure, whereas its medial border is formed by lacrimal notch. Now, on this surface, infraorbital groove and canal are located. This canal opens onto the facial surface of maxilla through infraorbital foramen. The posterior or infratemporal surface of maxilla is directed backward and laterally. This surface is pierced by several alveolar canals that transmit the posterior superior alveolar nerve and vessels. The maxillary tuberosity is a rounded eminence which is found on its postero-inferior aspect, and that is an important landmark for posterior superior alveolar nerve block. The medial surface of maxilla forms part of the lateral nasal wall. On its postero-superior aspect lies the maxillary hiatus, that is an irregular opening. In front of this hiatus lies the nasolacrimal groove and canal through which nasolacrimal duct opens to the inferior meatus of nose. Maxillary sinus lies within the body of maxilla. It is largest paranasal sinus. It is pyramidal in shape. Base of this pyramid is directed medially, whereas apex is directed laterally. The maxillary sinus open into the middle meatus of nose through hiatus semilunaris. Roof of maxillary sinus forms the floor of orbit, whereas the floor has alveolar process of maxilla. The frontal process of maxilla articulates with the frontal, nasal, and lacrimal bones. Its lateral surface has got anterior lacrimal crest that gives attachment to the lacrimal fascia and medial palpebral ligaments, whereas its lateral surface forms the lateral wall of nose. The palatal process of maxilla is thick horizontal projection. It forms a large portion of floor of nose and roof of the mouth. Anteriorly in the midline, it has got incisive foramen through which nasopalatine nerve and vessels emerge. Posteriorly, it articulates with the palatine bone, and these palatine bone harbor greater and lesser palatine foramens. From greater palatine foramen, greater palatine knob and vessels emerge. Zygomatic process of maxilla is a pyramidal lateral projection and its superior surface is rough for the articulation with the zygomatic bone. Alveolar process of maxilla bears the socket for the roots of upper teeth. Buccinata muscle arise from the posterior part of its outer surface up to the region of first molar. Now coming on to the applied aspect. The infraorbital depression is lying at least 5 to 6 meters below the infraorbital margin. This infraorbital depression houses the infraorbital foramen, and this depression is a landmark for infraorbital nerve block. Any hematoma developing while giving this particular nerve block is easy to control because one can apply direct pressure against the bone. Infraorbital foramen opens inferomedially, and in certain individuals where this foramen is large and canal is large enough, this can lead to inadvertent intracanal passage of the needle, especially with the central incisor approach while giving infraorbital nerve block. Whereas this can be avoided by following bicuspid approach, as this needle tip would hit the roof of the infraorbital foramen and it won't go inside the foramen. Now, maxillary facial surface is very porous, and that is why effective infiltration anesthesia is possible in the maxillary teeth. The wide infraorbital foramen and wide infraorbital canal can lead to deep penetration of local anesthetic solution while giving infraorbital nerve block, and this intraorbital passage of the local anesthetic solution can lead to transient diplopia. The posterior surface of maxilla is near the infratemporal fossa. Infratemporal fossa communicate to the temporal fossa, pterygopalatine fossa and orbit. The solution for posterior superior nerve block is deposited near the posterior or the infratemporal surface of maxilla in the fossa. Since this infratemporal fossa can communicate to the orbit through inferior orbital fissure, the solution deposited here might go within the orbit, resulting in transient diplopia. The hematoma with the posterior superior alveolar nerve block is quite significant and is a matter of concern, just because this area is highly vascular, which has got pterygoid venous plexus and the maxillary artery. The posterior superior alveolar nerve block is given in this location. The damage to these two structures result in massive bleed in this particular region, and which is very difficult to control by application of direct pressure, because this particular area is guarded from the lateral side by a ramus of mandible and zygomatic arch. These are the references for this particular lecture. Thank you so much.